So I think it's really hard to talk about hypercoagulability without mentioning Virchow's triad, right? So as you guys remember, Virchow or Dr. Virchow was I think it's 19th century German physician slash scientist who came up with this very neat idea of Virchow's triad. Basically, he described three groups of factors that may predispose a patient, whether it's a person or animal, to thrombosis, pathologic clot formation. The first group of these factors would be blood stasis, or poor kind of blood flow. And it could be caused by things like vessel compression, reduced cardiac output. So the classic example would be post CPR state. So the blood flow is extremely decreased. And the best case scenario, you're going to achieve like 30% of normal cardiac output during the CPR. And during that time, the blood flow is very poor, and that triggers thrombotic events. So we know that CPR is associated with thrombosis. And one of the reasons is due to the blood stasis. So the blood is flowing so poorly during CPR that it triggers the thrombi formation. The next risk factor for stasis would be immobility, right? So if you have especially a large animal that is just lateral recumbent for a long time, that may trigger thrombosis. If a patient has hyperviscosity syndrome, whether it's from polycythemia or increased plasma protein levels, for example, due to cancer. So all of that may cause poor blood flow, and that may trigger thrombosis. The next group of factors is vessel wall injury. So you guys remember that all vessels, arterial, venous, capillaries, are aligned, covered by endothelial lining. And that endothelial lining is very important because it prevents blood from clotting. And endothelium has a layer of glycocalyx, and glycocalyx has heparin-like substances in it that prevents this clotting. It's also very smooth and designed to prevent blood from clotting. So when this layer of endothelium and glycocalyx is disrupted by surgery, trauma, tumor invasion, or catheterization, that triggers thrombotic event. Now, if it's a minor injury and it's contained to a focal area, that's not a problem. That's very physiologic. But if it's a widespread injury to multiple parts of the body, that may cause very severe thrombosis and thromboembolic event. And the last class of factors that will lead to thrombosis is called hypercoagulability, which is going to be the topic of our discussion today. And one thing to remember that you don't have to have all of these three factors present at the same time. So a patient may develop a large clot even with one of these factors being present. So whether it's stasis or vessel wall injury or hypercoagulability, and even worse, if you combine these factors together in the same patient, the risk will go up significantly. So before we move on, I think it's really important to understand a couple of things. So one, when the patient is hypercoagulable, which means that this patient has increased tendency to clot, it doesn't mean this patient is going to develop thrombosis, right? It just means this patient going to be at higher risk of thrombosis. So hypercoagulability is not equal to thrombosis. It just means there's a higher risk of thrombosis. The second important concept is that if you did not identify evidence of hypercoagulability, you did a bunch of testing and everything came back normal, it does not rule out the possibility of thrombosis. Because remember, there are a lot of different factors that may lead to thrombosis, such as vessel wall injury or stasis, that may be the sole reason for thrombosis, even without hypercoagulability. I like to look at this kind of hypercoagulability situation as a scale, right? As a balance between procoagulant factors and anticoagulant factors. Hypercoagulability, as I defined previously, is again a state where a patient has increased tendency to clot. In human literature is also known as thrombophilia. So again, in vet textbooks, you're going to hear hypercoagulability, in human thrombophilia, but you can use them interchangeably. So they're very similar kind of synonyms. In a healthy animal, everything is in balance. You have procoagulant factors, anticoagulant factors. They're in balance with each other. So the patient does not develop pathologic clotting. Only physiologic if there is some type of traumatic event. And in order to prevent hemorrhage, you're going to form a clot that will stop the bleeding. That's very normal. And then this clot will get destroyed over time. We're going to call it fibrinolysis. Fibrinolysis is a natural adaptation to clot formation. So if you have a clot, your fibrinolytic system going to get activated over time. So you can remove that clot from the circulation so it doesn't impede the blood flow to the tissues. Now, in a patient that is hypercoagulable, there is a mismatch between procoagulant and anticoagulant factors. So one scenario is that in a patient, you're going to see increased number of procoagulant factors, which could be increase in number of tissue factor bearing cells. It could be increase in platelet count, could be increase in coagulation factors. For example, fibrinogen, right? So fibrinogen is one of the clotting factors. And if your patient has extremely high fibrinogen level, it's been shown that will correlate with increased coagulation or hypercoagulability, like in Sophie, patient that we started talking about earlier during this session. Also, in a patient with a severe platelet count elevation, or also known as thrombocytosis, they may also be prone to thrombosis. So a patient with 1 million platelets per microliter, you're going to see increase in hypercoagulability. On the other hand, you have natural or endogenous anticoagulants, such as antithrombin or some other factors. And if you have a reduction in anticoagulants, endogenous anticoagulants, you're going to tilt or tip your scale to the left, meaning that your patient will become more hypercoagulable or procoagulable, and that could cause thrombosis. On the other hand, there's fibrinolysis, right? So we mentioned fibrinolysis prior. It's a natural system in the body that will destroy clot over time. If you inhibit fibrinolysis by giving a drug, or you have a disease process that does that, you may also shift your scale to the left towards the more hypercoagulable state. For example, tranexamic acid or aminocaproic acid is a drug that is designed to inhibit fibrinolysis. And if you give aminocaproic acid to a completely healthy animal without any bleeding or problems with fibrinolysis, you're going to make this patient hypercoagulable because you're turning off this important part of the hemostatic system. All right, so how do we diagnose hypercoagulability in our patients? Unfortunately, it's not always straightforward. And similar to shock, it is a clinical diagnosis. So you have to look at multiple parameters and put all of these pieces together to solve this puzzle, whether your patient is hypercoagulable, normal coagulable, or hypocoagulable. So we always start with historical information. And if the patient had a history of thrombosis, that should be a red flag, right? That means this patient likely going to have higher risks of thrombosis in the future. You may measure different clotting factors. Again, remember that scale, right? Procoagulants, anticoagulants. if you measure some of these components and put them together as a net effect, you may decide whether a patient is likely going to be hyper or normal coagulable. You can check PT-PT. You can measure fibrinogen level, D-dimers, antithrombin as the main endogenous or natural anticoagulant. You can do viscoelastic testing as a global way to assess the whole hemostatic system. And you can also perform some diagnostic imaging to try to identify the active clot, right? Because if you can see a clot in the splenic vein, for example, on the abdominal ultrasound, that's very specific and definitive for thrombosis. This patient is forming clots, and this patient has activation of coagulation system for some reason, whether it's related to blood stasis, vessel wall injury, for example, from local neoplasia, or there's hypercoagulable state behind. So again, during the next couple of sessions, maybe 3 sessions, we're going to talk about each of these parameters. And hopefully by the end of this series of lectures or sessions, you're going to have a good understanding of this topic and how you can apply it to clinical patients. So I think very important source of information that I encourage you to use in your clinical practice is called curative guidelines. So these guidelines, or I guess consensus statement, was published originally in 2019 in JVEC and then was updated. Some of these domains were updated in 2022. So basically, it's a team of criticalists, and I think there were a few internists who joined the team as well. And they came up with definitions of hypercoagulability and risk factors, treatment protocols related to the treatment of thrombosis. And since we're talking about hypercoagulable states, this domain number 1, where they defined populations at risk, would be the most helpful for our discussion. So what they tried to do here is to describe different grades of risks in patients with various conditions that could be associated with hypercoagulable states. So, for example, they divided a lot of conditions that we typically think about in terms of hypercoagulability into 2 big groups: high risk conditions and low to moderate risk conditions. So things like K9-IMHA, K9-PLN, or protein losing nephropathy, feline cardiac disease, especially with big left atrium, protein losing enteropathy or PLE, heartworm disease. So these are examples of high risk conditions that will increase the risk of clot formation or thrombosis. And if your patient has at least one of these conditions, typically that's enough to start antithrombotic therapy. And there are 3 kind of main classes of antithrombotics that we use in vet medicine, which are platelet inhibitors, such as clopidogrel, heparins, such as low molecular or unfractionated heparin, and oral anticoagulants. They also called DOAC, direct oral anticoagulants, such as rivaroxaban. So it works similar to heparin, but it's an oral form. So think about it as oral heparin. Now, always remember that when you start antithrombotics, you need to think about risks and benefits. And you always need to think about the risks of bleeding as well. So if your patient has a condition that makes it bleed, and you're considering antithrombotics, you should be really careful because you absolutely want to prevent clotting, but also you don't want to make them bleed. So in our case, in case of Sophie, she did have this ecchymosis. So we need to think about it because if we start antithrombotics and this patient bleeds out, it's going to be on us. So later we'll discuss how you sort out whether the risk of clotting outweighs the risk of bleeding, but it's something you always should think about when you start antithrombotics. Now, besides these conditions that I just mentioned, other things that may be higher risk situation would be combination of at least two or more low to moderate risk conditions, such as one of these. So if you have a patient with hyperadrenocorticism and carcinoma, one of these conditions is low risk, but if you combine them, that becomes high risk situation that warrants antithrombotics. Or if you have one low risk condition and then you confirm hypercoagulable state with your diagnostics, that would be another example. Or if you have a patient with active existing thrombus. So as I mentioned, you did ultrasound and there's a big, huge clot in the spleen. So that by itself confirms that this patient is prone to thrombosis and maybe an indication to start antithrombotics, even if there is nothing else in this patient that will predispose them to thrombosis. Now, low to moderate risk conditions would be things like epithelial cancers, such as carcinomas and round cell tumors, hyperadrenocorticism or Cushing's, exogenous use of glucocorticoids, acute pancreatic necrosis, sepsis, canine liver disease, feline protein-losing nephropathy, and feline IMHA. So if your patient has one of these conditions, again, they are associated with thrombosis, but at this point in time, based on the literature that we have and evidence that we have, the presence of just one of these conditions is not enough to start antithrombotics. So there is no strong recommendation to start antithrombotics just because they have one of these conditions. Again, you as a clinician may decide to start antithrombotics for some reason. So again, these are just recommendations and guidelines. You can always decide by yourself as case by case type scenario. But in general, based on available literature at that time, at the time of writing, they did not recommend starting antithrombotics just because they have one of these low to moderate risk conditions. And there are other things that you need to take into account. So, for example, did this patient have previous history of thrombosis? Did this patient have recent surgery trauma, central catheter placement, reduced mobility? So, all of these factors may also further increase risk of thrombosis or bleeding in case of surgery. And that's something you should keep in mind. So if I have a patient with, let's say, hyperadrenocorticism, and it has central line, and this patient is also potentially septic, now I'm leaning towards using antithrombotics because I have multiple things that make this patient high risk patient in terms of thrombosis.